Welcome to the World Health Organization Pulse Oximeter Instructional Video. The World Health Organization has recently introduced a surgical safety checklist as part of the Safe Surgery Saves Lives initiative. Measures to improve anesthesia safety are integral to the program. In many countries, pulse oximetry is mandatory for monitoring patients during anesthesia. Although pulse oximetry is a simple and reliable technology that can detect low levels of oxygen in the blood, it is only effective if the anesthesia provider understands how an oximeter works and what to do when low levels of oxygen are detected. This video explains how pulse oximeters work and how to use them properly. This video highlights essential information for all anesthesia providers who are not experienced in using pulse oximetry and may be beneficial for all members of the operating team. Physiology of oxygen transport. This section will cover three key concepts. 1. How is oxygen transported from the air to tissues? 2. What is the normal oxygen saturation in blood? 3. What is pre-oxygenation? Oxygen transport. Oxygen is essential to sustain life. Although all organs in the body depend on oxygen, the brain and heart are especially sensitive to low oxygen levels. The presence of low oxygen levels anywhere in the body is known as hypoxia. Hypoxia, lasting even for a few minutes, may be fatal. General anesthesia presents many opportunities for hypoxia to occur. Hypoxia may occur during obstruction of the airway, decreased breathing, blood loss, abnormal heart rhythms, equipment failure. Any one of these conditions may limit the delivery or transport of oxygen to tissues, resulting in hypoxia. If not managed correctly, these circumstances may lead to serious injury or death. Oxygen is transported in the blood by a protein called hemoglobin, Hb, contained in red blood cells. After oxygen is breathed into the lungs, it combines with the hemoglobin in red blood cells as they pass through the blood vessels in the lungs. The heart pumps blood continuously around the body to deliver this oxygen to the tissues. Proper oxygen delivery requires the following. Oxygen must be breathed in, or inspired, from the air or anesthesia circuit into the lungs. Oxygen must pass from the air spaces in the lung, called the alveoli, to the blood. The blood must contain enough hemoglobin to carry sufficient oxygen to the tissues. The heart must be able to pump enough blood to the tissues to meet the patient's oxygen requirements. The patient must have enough blood to ensure blood with oxygen reaches all the tissues. Each gram of hemoglobin combines with 1.34 milliliters of oxygen. Therefore, in blood with a normal hemoglobin concentration of 15 grams per deciliter, 100 milliliters of blood carries approximately 20 milliliters of oxygen, combined with hemoglobin. In addition, a small quantity of oxygen is dissolved in the blood. Normal saturation. 1 molecule of hemoglobin can carry up to 4 molecules of oxygen. If all 4 binding sites on the hemoglobin molecule are carrying oxygen, the molecule is termed saturated with oxygen. The measure of saturation of all hemoglobin molecules in arterial blood is known as the arterial blood oxygen saturation, or SaO2. If every molecule of hemoglobin contained in the blood is fully saturated, the SaO2 is 100%. Most of the hemoglobin in blood combines with oxygen as it passes through the lungs. A healthy individual with normal lungs breathing air at sea level will have an arterial oxygen saturation of 95 to 100%. Blood that is collected from the tissues travels in the veins and contains less oxygen than blood in the arteries. Normally, venous blood has an oxygen saturation of around 75%. During the administration of a general anesthetic, if the oxygen saturation drops below 90%, the patient is considered hypoxic and must be treated immediately. Arterial and venous blood appear different in color due to the difference in hemoglobin saturation. Due to the higher oxygen saturation, arterial blood looks bright red, while venous blood, with a lower oxygen saturation, appears dark red. When patients are well saturated with oxygen, their tongues and lips appear pink. When they are not well saturated, they appear blue. This bluish appearance is known as cyanosis. It is often difficult to detect cyanosis clinically, particularly in dark-skinned patients, because it may not become apparent until the oxygen saturation has dropped to clinically dangerous levels, below 90%. This is especially critical in anemic patients who may not appear cyanotic, even in the presence of an extremely low oxygen saturation. Preoxygenation. In the average-size adult, the heart normally pumps about 5,000 milliliters of blood per minute to the tissues. This delivers about 1,000 milliliters of oxygen to the tissues per minute. The cells in the tissues extract oxygen from the blood for metabolism, normally at a rate of approximately 250 milliliters per minute. This means that if there is no oxygen exchange in the lungs, the oxygen in the blood would be depleted within 3 minutes. For this reason, anesthesia providers have patients breathe 100% oxygen for several minutes prior to induction of anesthesia. This technique, called preoxygenation, creates a reservoir of oxygen in the lungs and may avoid hypoxia if oxygen delivery is delayed, adding potentially life-saving minutes. The pulse oximeter. There are many different models of pulse oximeters available that may differ in appearance and size. However, the underlying function is the same in all of them. This section will cover 3 key concepts common to all pulse oximeters. 1. What does a pulse oximeter measure? 2. What are the parts of a pulse oximeter? 3. How to use the pulse oximeter. What does a pulse oximeter measure? The pulse oximeter measures 2 numerical values: the oxygen saturation of hemoglobin in arterial blood and the pulse rate. The value of the oxygen saturation is given together with an audible signal that varies in pitch depending on the oxygen saturation. A falling pitch indicates falling oxygen saturation. Since the oximeter detects the saturation peripherally on a finger, toe, or ear, the result is recorded as the peripheral oxygen saturation, described as SpO2. The pulse rate is measured in beats per minute, averaged over 5 to 20 seconds. Some oximeters display a pulse waveform, or indicator, that illustrates the strength of the pulse being detected. This display indicates how well the tissues are perfused. The signal strength falls if the blood flow becomes inadequate. Learning point. A pulse oximeter is an early warning device. A pulse oximeter continuously measures the level of oxygen saturation of hemoglobin in the arterial blood. It can detect hypoxia much earlier than the anesthetist can see clinical signs of hypoxia, such as cyanosis. This ability to give early warning has made the pulse oximeter essential for safe anesthesia. The monitor and the probe. A pulse oximeter is made up of the monitor, containing the batteries and display, and the probe that senses the pulse. The pulse oximeter monitor. The monitor contains the microprocessor and display. The display shows the oxygen saturation, the pulse rate, and the waveform detected by the sensor. The monitor is connected to the patient via the probe. During use, The monitor updates its calculations regularly to give an immediate reading of oxygen saturation and pulse rate. The pulse indicator is continuously displayed to give information about the blood flow. The audible beep changes pitch with the value of oxygen saturation and is an important safety feature. The pitch drops as the saturation falls and rises as it recovers. This allows you to hear changes in the oxygen saturation immediately, reducing the need to refer to the monitor. The monitor is delicate. It is sensitive to rough handling, excessive heat, and exposure to liquids. The monitor can be cleaned by gently wiping with a damp cloth. When not in use, it should be connected to an electricity supply to ensure that the battery is fully charged. The pulse oximeter probe. The oximeter probe consists of two parts, the light-emitting diodes and a light detector, called a photodetector. Beams of light shine through the tissues from one side of the probe to the other. This light is absorbed by both tissues and blood. The amount of light absorbed by the blood varies with the oxygen saturation of hemoglobin. The photodetector detects the light transmitted as the blood pulses through the tissues, and using this information, the microprocessor calculates a value for the oxygen saturation, known as SpO2. In order for the pulse oximeter to function, the probe must be placed where a pulse can be detected. The light-emitting diode and the light detector must face each other in order for the light detector to properly read the amount of light passing through the tissues. When the pulse oximeter is on, a properly functioning probe will emit a clearly visible red light. Probes are designed for use on the fingertip, toe, or earlobe. There are several different types. Hinged probes are the most popular, but are easily damaged. Rubber probes are the most robust. However, the wraparound design may constrict the blood flow through the finger if it is too tight. Ear probes are lightweight and are useful in children or patients with constriction of blood vessels. Smaller probes have been designed for children, but an adult hinged probe may be used on the thumb or big toe of a child. For finger or toe probes, the correct orientation of the nail bed is marked on the probe by the manufacturer. The oximeter probe is the most delicate part of a pulse oximeter and is easily damaged. It is important to handle the probe carefully. The probe connects to the oximeter using a connector with a series of fine pins that can also be easily damaged. It is critical to always align the connector correctly before attempting to insert it into the monitor. Similarly, pulling the probe from the machine by the cable may damage the cord. Therefore, it is necessary to always grasp the connector firmly between finger and thumb when unhooking the probe from the monitor. When not in use, the oximeter probe cable may be loosely coiled for storage or carrying, but should not be coiled too tightly, as this will damage the wires inside the cable. The lens and detector should be kept clean. Use soapy water or an alcohol-soaked swab to gently clean dust, dirt, or blood from the probe. Learning point. In order to get a satisfactory reading, the probe must be emitting a red light and must be correctly positioned to detect pulsatile blood flow. How to use the pulse oximeter. Turn the pulse oximeter on. It will go through internal calibration and checks. Select the appropriate probe with particular attention to correct sizing. Make sure the intended placement site is clean and remove nail polish if necessary. Connect the probe to the pulse oximeter. Position the probe carefully. Make sure it fits easily without being too loose or too tight. Avoid placing the probe on the same arm as the blood pressure cuff. Allow several seconds for the pulse oximeter to detect the pulse and calculate the oxygen saturation. Look for the displayed pulse indicator to ensure that the machine has detected a pulse. Without a pulse signal, readings are meaningless. Once the unit has detected a pulse, the oxygen saturation and pulse rate will be displayed. Adjust the volume of the audible pulse beep to a comfortable level. Never use on silent. Always make sure the alarms are on. Like all machines, oximeters may occasionally give a false reading. If in doubt, rely on your clinical judgment rather than the machine. Learning point. The function of the oximeter probe can be checked by placing it on your own finger. If no signal is obtained on the oximeter after placing the probe, check the following. Is the probe working and correctly positioned? Check that the probe is emitting a red light and try another placement site. Does the patient have poor blood flow? Check for low blood flow, especially due to blood loss, heart problems, or shock due to infection. If low blood pressure is present, resuscitation of the patient is required immediately. The signal will improve when the clinical condition of the patient improves. Check the temperature of the patient. If the probe placement site is cold, gently rubbing the site may restore a signal. Pulse oximeter alarms. Alarms alert the anesthesia provider to clinical problems. There are 4 possible alarms. Low saturation emergency. Warns of SpO2 at or below 90%, indicating hypoxia. In healthy patients under anesthesia, the SpO2 should be 95% or above. If SpO2 is 94% or below, the patient must be assessed quickly to identify and treat the cause. SpO2 of less than or equal to 90% is a clinical emergency and should be treated urgently. No pulse detected warns of loss of pulse signal. This alarm sounds if the probe slips off the placement site. However, it may also be an important indicator of low blood pressure, blood loss, or cardiac arrest. Check the probe site quickly and then assess the patient. Low pulse rate warns of decreasing heart rate. High pulse rate warns of elevated heart rate. Pulse rate alarms are useful to alert the anesthesia provider that the heart is beating too quickly or too slowly. Because children normally have higher heart rates than adults, but the same oxygen saturation, this alarm may erroneously sound in stable children. The high pulse alarm may be triggered by light anesthesia, inadequate pain relief, atropine, ketamine, hypovolemia, fever, or arrhythmia. The low pulse alarm may be triggered by decreased heart rate secondary to nerve reflexes, deep anesthesia, or severe hypoxia. Highly trained athletes and patients taking beta blockers may also have slow pulse rates. Limitations of use. Several factors can interfere with the correct function of a pulse oximeter. Light, bright light, such as the operating room light or sunlight, directly on the probe may affect the reading. To avoid this, shield the probe from direct light. Shivering. Movement at the placement site may interfere with the probe's ability to detect a signal. To resolve this issue, remove the probe and place it on a less mobile site. Pulse volume. The oximeter only detects pulsatile flow. When the blood pressure is low due to hypovolemic shock, low cardiac output, or cardiac arrhythmia. The pulse may be weak, and the oximeter may not be able to detect a signal. Restoration of a strong pulse will correct this issue. Vasoconstriction reduces blood flow to the extremities. The oximeter may fail to detect a signal if the patient is vasoconstricted. Carbon monoxide poisoning may result in a falsely high saturation reading. Carbon monoxide binds very well to hemoglobin and displaces oxygen to form a bright red compound called carboxyhemoglobin. This is often an issue in patients following smoke inhalation from a fire. Anemia. Pulse oximeters function normally in anemic patients who have reduced numbers of red blood cells. In an extremely anemic patient, the oxygen saturation may be normal, 95 to 100%, but there still may not be enough hemoglobin to carry sufficient oxygen to the tissues. During anesthesia, the patient should receive 100% oxygen to improve oxygen delivery to the tissues. Learning point. Low blood flow due to blood loss is the most common cause of a weak pulse oximeter signal during anesthesia. Low body temperature should also be considered. Causes of hypoxia during anesthesia. There are several causes of hypoxia during anesthesia. Airway. An obstructed airway prevents oxygen reaching the lungs. The tracheal tube can be misplaced, such as in the esophagus. Aspirated vomit can block the airway. Breathing. Inadequate breathing prevents enough oxygen reaching the lungs. Severe bronchospasm may not allow enough oxygen to exchange in the lungs. A collapsed lung will decrease the patient's ability to breathe. High spinal anesthesia may cause inadequate breathing. Circulation. Decreased blood flow prevents oxygen from being transported to the tissues. Common causes include blood loss, abnormal heart rhythm, or heart failure. Drugs. Deep anesthesia may depress breathing and circulation. Many anesthetic drugs cause a drop in blood pressure. Muscle relaxants paralyze the muscles of breathing. Anaphylaxis can cause bronchospasm and decrease the heart's ability to pump. Equipment. Problems with the anesthetic equipment may include disconnection or obstruction of the breathing circuit. Problems with oxygen supply may include an empty cylinder or oxygen concentrator not working. Problems with the monitoring equipment may include a battery failure in the oximeter or a faulty probe. Learning point. When hypoxia occurs, it is essential to decide whether the problem is with the patient or the equipment. After a quick check of these common patient problems, make sure the equipment is working. How to respond to hypoxia. During anesthesia, low oxygen saturations must be treated immediately and appropriately. The patient may become hypoxic at any time during induction, maintenance, or emergence from anesthesia. If the oxygen saturation is 94% or less, the appropriate response is to administer 100% oxygen, manually ventilate the patient, and correct the underlying problem. For example, if the patient has an obstructed airway and is unable to breathe oxygen into the lungs, the problem will only be cured when the airway is cleared. Whenever the patient has low saturations, administer high-flow oxygen and consider A, B, C, D, E. A. Airway. B. Breathing. C. Circulation. D. Drugs. E. Equipment. Specifically, consider the following. A. Is the airway clear? Is the patient breathing quietly without signs of obstruction? Are there signs of laryngospasm? Is there any vomit or blood in the airway? Is the tracheal tube in the right place? Airway obstruction is the most common cause of hypoxia during anesthesia. Airway obstruction is a clinical diagnosis that requires immediate attention. Unrecognized, inadvertent esophageal intubation is a major cause of anesthesia morbidity and mortality. An intubated patient who has been previously well saturated may become hypoxic if the tracheal tube becomes displaced, kinked, or obstructed by secretions. Check the tracheal tube and, if in doubt, take it out. If there is a problem with the airway, ensure that there is no obstruction. If breathing via a face mask, chin lift, jaw thrust. Consider an oropharyngeal or nasopharyngeal airway. Check for laryngospasm and treat if necessary. Check the tracheal tube. If any doubt about the position, remove and use a face mask. Suction the airway to clear secretions. Consider waking the patient if a problem arises immediately after induction. Consider intubation. A surgical airway is required in cases where manual ventilation and intubation fail. B. Is the patient breathing adequately? Look, listen, and feel. Are the chest movement and tidal volume adequate? Listen to both lungs. Is there normal bilateral air entry? Are the breath sounds normal? Any wheeze or added sounds? Is the chest movement symmetrical? Is anesthesia causing respiratory depression? Is a high spinal causing respiratory distress? Bronchospasm, lung consolidation, collapse, lung trauma, or fluid in the lungs may prevent oxygen getting into the lungs to combine with hemoglobin. Drugs such as opioids, poorly reversed neuromuscular blocking agents, or deep volatile anesthesia may depress breathing. A high spinal anesthetic may paralyze the muscles of breathing. If the patient is not breathing adequately, assist ventilation with good tidal volumes to expand both lungs until the problem is diagnosed and treated appropriately. If there is sufficient time, consider a chest X-ray to aid diagnosis. If respiration is inadequate, ventilate the patient via a face mask, LMA, or tracheal tube. This will rapidly reverse decreased breathing due to drugs or a high spinal, and a collapsed lung will re-expand. Suction the lower airway to remove any secretions. Insert a nasogastric tube to relieve stomach distension. Suspect lung collapse in cases of reduced air entry on one side following trauma, central line insertion, or a supraclavicular brachial plexus block. In these patients, a hollow note on percussion may also be detected. Consider a chest X-ray for diagnosis and insert chest tube if necessary. In cases of suspected lung collapse with low blood pressure, decompress the pneumothorax emergently without waiting for a chest X-ray. C. Is the circulation normal? Is anesthesia too deep? Is there a high spinal block? Is venous return impaired by compression of the vena cava, gravid uterus, surgical compression? Is the patient in septic or cardiac shock? Normally, an inadequate blood flow is revealed by the pulse oximeter as a loss or reduction of pulsatile waveform or difficulty getting a pulse signal. If there is a problem with blood flow, feel for a pulse and look for signs of life, including active bleeding from the surgical wound. Check the blood pressure. Check the peripheral perfusion and capillary refill time. Observe for signs of excessive blood loss in the suction bottles or wound swabs. If the blood pressure is low, correct it. Check for blood loss. Give intravenous fluids as appropriate, normal saline or blood as indicated. Consider head down or leg up position or in the pregnant mother, left lateral displacement. Consider a vasoconstrictor drug such as ephedrine or phenylephrine. If the patient has suffered a cardiac arrest, commence cardiopulmonary resuscitation, CPR, and consider reversible causes, 4 H's, 4 T's, hypotension, hypovolemia, hypoxia, hypothermia, tension pneumothorax, tamponade, toxic effects, thromboemboli. D. Are all anesthesia drugs being given correctly? Excessive halothane or other volatile agent may decrease the heart's ability to pump. Muscle relaxants may reduce the ability to breathe if not reversed adequately at the end of surgery. Opioids and other sedatives may decrease breathing. Anaphylaxis causes cardiovascular collapse, often with bronchospasm and skin flushing. This may occur if the patient is given a drug, blood, or artificial colloid solution that they are allergic to. Some patients are allergic to latex rubber. If the problem is a drug effect, identify the drug causing the adverse effect. Stop the administration of the suspected drug and reverse effects as necessary. In anaphylaxis, stop administering the causative agent. Administer 100% oxygen. Give intravenous saline, starting with a bolus of 10 milliliters per kilogram. Administer adrenaline, and consider giving steroids, bronchodilators, and an antihistamine. E. Is the equipment working properly? Is there a problem with the oxygen delivery system? Does the oximeter show an adequate pulse signal? If there is a problem with the equipment, check for obstruction or disconnection of the breathing circuit or tracheal tube. Check that the oxygen cylinder is not empty. Check that the oxygen concentrator is working properly. Check that the central hospital oxygen supply is working properly. Change the probe to another site. Check that it is working properly by trying it on your own finger. If it is felt that the anesthesia equipment is faulty, use a self-inflating bag to ventilate the patient with air while new equipment or oxygen supplies are obtained. If equipment is missing, mouth-to-tracheal tube or mouth-to-mouth ventilation may be life-saving. It is important to treat each element of the sequence in order. After going through A, B, C, D, E, recheck them until the patient's condition has improved. Learning point. If SpO2 is 94% or below, give 100% oxygen, hand ventilate, consider A, B, C, D, E. Conclusion. We hope that this video has helped you to understand how a pulse oximeter works and how it can help you improve patient care during the administration of anesthesia.